Hi everyone, my name is Court Wing and this is REMAP Therapeutics. Innovating, exploring, and developing the intersection between chronic pain and psychedelics. This is an introductory episode, coming out with this now because yesterday Scientific American published an article called "Can Psychedelic Drugs Treat Physical Pain?" So this is something I've been exploring for the last year and a half, and I've been involved in movement and pain treatment for the last 30 years, very, very specifically within the applied neuroscience field for the last 15 through an organization and certification called Z Health. Just by way of introduction, I was a study participant in NYU's study trial for psilocybin for major depressive disorder. I went through in March 2020 and experienced full remission. I was very fortunate to receive the actual target substance and not a placebo. Outside of that full remission of the depression, which was profoundly impactful on my life, I also experienced multiple lateral benefits involving chronic pain and other similar conditions that were very unexpected. I started informing the researchers almost immediately, and 10 days later, the New York City government obviously shut down all of New York due to the pandemic, and I've been researching ever since. But the day after my dose, I saw immediately that there was going to be profound implications of psychedelics on treating chronic pain. Saw it all at once, how a whole class of treatments could be profoundly modified because psychedelics are an impact booster for neuroplasticity. So I thought today I'd just discuss a little bit about this Scientific American article. It's going to be a sea change from now on. I think we'll be looking at a very different landscape going forward as far as how chronic pain is treated. But I thought I'd just go over it briefly, some of the interesting things they bring up in this article that I've been talking to professional researchers, funders, and doing presentations on. In fact, just had a presentation yesterday with Unlimited Sciences. I was very happy to present that to Del Jolly and his inner circle there. Did a co-presentation with Jim Harris of Perpetual Weekend. Just a great presentation on spinal injury recovery, chronic pain, and psychedelics. So hopefully that will be making it out into social media soon, but in the meantime. So the article opens up with a discussion of a person under the pseudonym Kevin, who's had type 1 diabetes since they're 11, that has multiple implications in terms of circulatory complications, typically to the peripheral nerves, as well as having some vision issues. I've had friends in my life with type 1 diabetes, and these are things that vision loss is always an issue for them that they have to be mindful of. But so this person grew up with a loss of vision and peripheral neuropathy. So peripheral neuropathy, that's a loss of signal because of nerve damage. So that almost always results in a type of chronic pain. Loss of inflammatory control, due to the damage caused by type 1 diabetes. So he was in pain from that. And then in 2019, it says here, he developed colon cancer. As a result of the cancer, felt fairly anxious and depressed. That's not uncommon. And we'll see that dovetail in a later episode where some of the earliest studies in treating depression with psychedelics, and specifically psilocybin, were due to terminal cancer patients that had what's known as existential anxiety and depression. So regular antidepressants were ineffective on them because these people were depressed because they knew they were likely to soon die due to their disease, right? And they had very profound relief as a result of participating in psilocybin for depression trials, specifically for that condition. Anyways, so this person is depressed about their cancer, decides to take some psilocybin in the form of magic mushrooms for relief, has a pretty significant relief of the depression, but more profoundly finds that the pain from the peripheral neuropathy decreases, as well as within his gut, within his GI tract from the colon cancer, that also significantly decreases, right? So why would this be? We'll get on this more, but the GI tract, just to speak to it directly, has a pretty wide distribution of serotonin receptors, right? Serotonin is the main system on which psilocybin works, specifically through the 5-HT2A receptor, right? The GI tract is well populated with serotonin receptors, and likely through something known as descending inhibition, but also through affecting both his local and global inflammatory baseline, that pain was decreased. So we'll get into it, and then also the cortical representations of those areas that had been affected by that long-term chronic pain, right, or severe chronic pain, probably in the case of the cancer. Cortical representation, the mapping in his mind for those areas, had also been altered, but psilocybin is well known for normalizing and reorganizing those areas into what is their default healthy state, right? The mapping gets altered over time through repeated pain signals, becomes maladaptive. We also see that happening on a spectrum into psychiatric disorders, right? Where someone with depression has something called iterative rumination. Same thought, same negative thought keeps happening over and over again, right? Very difficult to shake. We're going to get further into this article about a little bit about that mechanism, but you can just say, here's the thing to understand. When we're talking about chronic pain or we're talking about chronic psychiatric conditions, they're on a spectrum, right? It seems like there's something separate, but there are components that are shared between both, and both can be profoundly impacted by the use of therapeutic psychedelic therapy. So this person takes psychedelics, sees improvement in both of these things, and there are others out in the field there that have been exploring how psychedelics will affect chronic pain. So it's mentioning here, in this past May, New York City-based multi-million-dollar startup called Mind Medicine is exploring using LSD and probably a modified psychedelic to treat chronic pain. I was aware that it would treat chronic pain because of some profound resolution I had in my session. Started immediately doing research the following day, talking to the researchers there at NYU, how I was dead convinced that this was going to make a huge impact here. But very fortunately, 3 months after my session, Joel Castellanos and other researchers at the University of California, San Diego, put out a position paper specifically dealing with a review of chronic pain psychedelics and the likely mechanisms that were involved, right? So there's multiple companies that have been working on this. I have been talking to funders, investors, researchers throughout this time saying, hey, this is going to make a huge difference here. But there's evidence, and MindMed's chief medical officer is also discussing that there's compelling preclinical evidence that psychedelics work via psychological mechanisms, but also might have direct effects on descending pain pathways. So some of that descending pain pathway research is coming out of Charles Nichols' lab, right? They've been doing very consistent work on those 5-HT2 receptors and how they're affecting pain expression via what's known as descending pain pathways. Some of that's via spinal thalamic tracts. The spinal thalamic axis or circuit is responsible for certain types of pain. That's a structure up in the brain that's also sensing temperature. So there's some correlation there, and we'll see where those two intersect in a little bit here. So there's multiple researchers out there also working on very specific types of chronic pain. One in particular is phantom limb pain. So at UCSD, they did a pilot. There was a case study involving a researcher and reporter named Albert Lin, who had a limb loss injury and had the limb removed after it was crushed in an accident. Thought he was going to be able to put on one of these new composite artificial limbs, get back to his very active lifestyle, but immediately started having severe chronic pain, right? He was very fortunate to be at UC San Diego because that's where V.S. Ramachandran, the noted neurological researcher, resides, who is also the person that developed what's known as mirror visual feedback therapy, right? Mirrorbox therapy. So when someone suffers a limb loss, it creates a aspect known as a deafferentation. Deafferentation, afferent signals are the signals going up the large fibers, up to the CNS, into the central nervous system, right? And deafferentation is the loss of that signal. Loss of that signal from an evolutionary survival perspective is very, very significant, right? That is a extinction level event, as it were, right? Because if in an evolutionary context, you lose a limb, you're probably bleeding to death, right? So anything that's creating a loss of signal from there is a major alarm bell to the nervous system, right? So, but if it's not addressed, that signal, that loss of signal in this case, starts to create cortical reorganization, changes in the brain, in the mapping for those structures, where even though the limb loss is healed, the signal persists. The signal persists because there's no information coming from there. So Mirrorbox therapy, or mirror visual feedback, is you put this angled mirror over the stump, or let's say a crushed limb or a limb that's affected by stroke, and you look at the reflected image of your remaining limb. Universe willing, you still have one that's functioning and pain-free, right? And you look at that image of the reflected limb, that creates enough sensory input and feedback to replace that deafferentation and provide input into that cortical representation of the missing limb. And for many people, the pain is instantly gone. But in the case of Albert Lin, just to go on a bit about this here, he would do it, and as long as he's in the acute phase, or actually under the reflected image, the pain was gone. But as soon as he would stop, the pain would fairly rapidly return. And then he found out about using high-dose psilocybin, probably via magic mushrooms, also had a very strong analgesic, pain-relieving effect. And likely he heard about it because of the high success rate people with cluster headaches had through an organization called Cluster Busters. They found that using high-dose psilocybin and LSD, right, would relieve them and interrupt cycles of cluster headaches. Cluster headaches are among the most painful human experiences known, right? It's known as the suicide headache, right? Unfortunately, because sufferers prior to this, some of them, 3 times the rate of suicide of average population, because the pain was so bad. that's how they'd seek relief. So he took the high dose psilocybin and found relief from it. But like many of the people within the cluster headache community, there's something known as a slapback initially, where you take it, there's pain relief, but then it comes back kind of even worse. So he told the lab where he was doing the work with V.S. Ramachandran on the Mirrorbox therapy what had been happening. And they speculated about how to solve it, but apparently his life partner at the time, I believe his wife, not completely sure, suggested that he combine the two. And this is almost exactly what I pictured the day after my psilocybin dose at NYU. I was familiar with Mirrorbox therapy. I was familiar with cluster busters, right? For actually years before my my remission from depression via psilocybin. But this paper, Joel Castellanos review, and then apparently going on unbeknownst to me, what everybody at UC San Diego were doing was they found combining the two provided him immediate and profound and lasting, crucially, lasting relief, right? So it seems that psilocybin being an impact booster for neuroplasticity provides enough intensity and stickiness, for that effect to last. So that's discussed here, and in the article published here by Scientific American. Also, Yale is continuing to work, as it mentions here, on cluster headaches. In August, Oxford, England-based pharmaceutical startup Beckley Psytech, which is a part of the Beckley Foundation, which has been doing amazing work with multiple research arms of various universities. They're doing a fundraise for a 1B safety trial investigating low-dose psilocybin to treat a rare kind of headache called short-lasting unilateral neuralgia form headache attack. This is consistent with other headache research where it's showing that people with both cluster headaches and migraines are responding to even low-dose psilocybin. So it's very exciting amount of relief. Why low dose is important is because higher dose, as everyone knows, induces what's called the trip, the psychedelic experience. So people have a fairly profound, transformative experience through that, but for some people that can be disorienting and potentially disturbing based on what type of psychological material comes up. So it's useful in this case knowing that this can also work at sub-threshold or just above threshold perceptual changes. So also something else to be considered is that our previous models of pain are outdated and incorrect. Previously, there's this Cartesian level approach where, there's damage out in the body somewhere, and that sends an input via the nerves up to the pain center in the brain, and then that alerts us that there's damage. But the problem is pain is not a damage signal. This is an outmoded concept. What's being used now is called a biopsychosocial model. So there is a whole symphony of coordination between thoughts, beliefs, perceptions, and sensation about pain. And all of those work in concert, almost like a combination lock, before a pain neurosignature can be formed, right? So if you were going to hear something to remember from that is that pain does not equal injury, and injury does not equal pain. A lot of people think that pain is a sensation that's an input from the nerves, but in fact, pain is an output from the central nervous system. That's a perception, an output from the brain, right? So just keep that in mind. And pain is something that can actually be learned and practiced. That's how chronic pain can persist long past any tissue healing. So one concern that's brought up in here by one researcher, assistant professor of anesthesiology, Vivian Tofik, is her concern is potentially that there may be a dependency that could be developed on psychedelics in treating for pain. That's always something we should be concerned about, any type of dependency when we're talking about pain treatment. But something worth considering here very strongly is that psychedelics seem to have an anti-addictive quality. Why is that? Because over the course of several days, if you use psychedelics repeatedly, the effect will rapidly taper off and start to be almost resistant to creating a new effect until you go off them for a few days, allowing that nervous system to reset, right? Taking more doesn't make them like get stronger. It actually, you have to kind of pace that. And also crucially, multiple addictive issues are being successfully treated with psychedelic assisted psychotherapy. So cocaine addiction, nicotine cigarette addiction, right? Heroin addiction via various, or opioid addiction via various psychedelics, are alcoholism too, are being successfully treated with psychedelics. In fact, a research grant and permission was just given to Matt Johnson at Johns Hopkins in order to treat nicotine addiction. The early results from treating a nicotine addiction are pretty amazing. At 6 months, treating pack-a-day 20-year smokers, there is an 80% compliance rate still. 6 months later, 80% of the people that entered psilocybin studies for nicotine addiction are still being compliant. That is not smoking after 20-year pack-a-day habits. So there's just nothing else that's touching that. And they also touch in this article on early work by Eric Cast, who's a researcher in the Chicago area in the early 60s, who worked with profoundly ill cancer patients, and the effect that LSD had against pain from essentially terminal cancer versus classic opioids at the time, Dilaudid and Demerol, very, very strong opioids. And in fact, the LSD turned out to be far more effective, but it was a brief study. Interestingly, there were some ethical issues with that because I believe at the time he did not get their permission exactly to dose them with LSD. And so many people said, yes, this worked better, but it was a weird experience, so I'm not sure if I'm ready to do that again. There's strong evidence, though, that LSD, this has been known for a while now, but there's some very recent studies now that LSD has a analgesic effect, a pain relieving effect. One of the ways that this is known is that they did a double-blind placebo trial of a low dose or threshold, just either sub-perceptual or just past threshold. So maybe starting to feel a little bit of something, but not very much, not large visual distortions or anything like that. But they did a cold water test. So remember earlier I mentioned the spinal thalamic pathway. It's responsible for detecting the sensation of cold, as well as processing most noxious stimuli, including pain, right? So within current research methods, a cold water test is a pretty good way of determining somebody's pain tolerance without directly causing them pain. So usually you'll submerge your arm or your legs. So a hand or a foot, which is very replete with lots of receptors, as I'm sure you've felt in your own life. And why it's a problem, going back again, why that's such a particularly big problem for people with type 1 diabetes or type 2 diabetes that are suffering from neuralgia. And because those areas are so replete with receptors, the mapping or that cortical representation in the brain, it's very big. It's very big. So the pain is like also very big, right? Anyways, so going back to the cold water testing. So one way of testing people's pain tolerance is cold water submersion. And they found with Lowdose LSD that compared to people not on it, that their pain tolerance actually went up. I believe is around a little over 20%. So that's pretty good, honestly. Of course, you always have to consider in pain tolerance trials, there's often a significant placebo effect, but there's strong evidence that this in fact is an actual pharmacological effect, because there were earlier pilot studies around the same time as Eric Cast of LSD and phantom limb pain. In fact, I've done a fair bit of research digging those up. We're going to do a completely separate episode on really how on target those Japanese researchers were, both with the mechanism of action, choosing to use low dose instead of high dose LSD, and in fact, profoundly understanding that this was this was altering what are known as homuncular representations. That's mapping various brain maps of various body limbs and locations, and that movement was intrinsic to its success. We're going to get into a whole episode on that, but going on here, there's a little bit more of talk in this article about, let's see here, just give me a second. They talk here about ratings of the pain tolerance from subjects who received LSD were comparable to those in studies with opioids and like oxycodone and morphine, leading authors to conclude in Journal of Pharmacology that low doses of LSD might constitute a novel pharmacological therapy. So just keeping in mind, this is work that was done at Maastricht University, where they're looking on studies of using psychedelics for fibromyalgia. There's multiple places that are preparing to do fibromyalgia studies, because this is a prevalent condition that's been somewhat treatment resistant, and which is significant. And remember, for the longest time, people with fibromyalgia were dismissed as having more of a psychological condition, which is extremely demoralizing when you're in profound pain, and people can't pin it down, and then they just say it's all in your mind. Well, yes, but it has a direct effect out there in the receptor loop, right? So a little bit of that Cartesian thinking still pervading and influencing some doctors that are a little bit behind what the current modeling is. It's a biopsychosocial model. All of those things have an effect here. And in fact, they mentioned that Boris Heifetz, who's Stanford medicine anesthesiologist who studies pain as well, has his own lab, the Heifetz lab, has had some great discussions online about what's going on. But he also says that, rapid acting psychiatric therapies, which include psychedelics, they have a focus on the serotonin. He thinks that's not the whole picture. He's in fact calls it a red herring. He thinks that because it creates depression relief, that has a profound cascading effect into the perception and your sense of identity with pain, right? So there's a profound, when people get chronically ill, chronic pain is a chronic illness, it alters your sense of self. It alters your sense of agency. It alters your self-image. In fact, your self-image reforms around being a person with chronic pain, right? So that creates a sense of grief, a sense of loss, a loss of agency, real demoralization, right? And as a result, a lot of accompanying depression or anxiety, similar to when people get terminal cancer, they get that existential anxiety and depression, right? So by treating the depression through the psychedelics, high dose psychedelics, as Johns Hopkins early work in the aughts established, high dose psychedelics are very reliably occasioning mystical experiences. Mystical experiences are well noted throughout history, with creating a profound transformation in both psychiatric as well as physiological illnesses, right? So Boris Heifetz here thinks a lot of what's happening is a change in psychological relationship to one's pain. I will politely disagree. I think there is far more involved, though he is a Stanford anesthesiologist. So, but I'm going to disagree. I think there's more involved here. I think there's a lot more that's happening in terms of cortical reorganization, as well as what's going on down at the receptor level, as well as what Charles Nichols is discussing in terms of descending inhibition, right? I think it gets to be even more. At some point, I'm going to go over essentially what I believe is one of the main ways that the use of psychedelics has to be done to treat chronic pain. It can't be done passively. It has to be actively done. There has to be active remapping. Anyways, one of the researchers at UC San Diego named Ziden agrees that, chronic pain is really just this comorbid snowball of shit, right? A whole class of things going on all at the same time. Like I said, there's almost like it's a combination lock. Biopsychosocial. It has to be a certain way this way, certain way that way, certain beliefs, certain expectations, all kind of happening at the same time. Usually there's this cascade, so it's known as the vicious psychological circle and the vicious physiological circle. And it's almost this figure eight of descending chaos, where one thing adds up on another, making things get worse and worse. Very hard to get out of. But that's also one of the reasons why psychedelics may be profoundly beneficial here. And a lot of that revolves around Dr. Robin Carhart Harris's, and forgive me for getting his first name, Dr. Eric Frisson's, Rebus model for why psychedelics work for treating rigid thinking psychiatric disorders like anxiety, depression, very specifically PTSD. So Rebus is relaxed beliefs under the influence of psychedelics, right? We're going to do a whole separate episode on that, and that's been the kind of the core of what's been my presentation for why, due to the revolution in neuroimaging over the last 15 years, you have these two concurrent groups, psychedelic researchers and chronic pain researchers, both studying nearly the same mechanism and not realizing they overlie each other, right? So Robin's Rebus model shows that, interestingly enough, if you look at where it's talking about top-down modulation versus bottom-up error correction processing, that in that model, for anyone that was involved with chronic pain research, they would immediately been able to see there was a prediction for being able to deal with chronic pain there, and if you just look at the literature and all the case studies out there, and honestly field reports of people that have been doing this on their own, the evidence has been there all along. So I'm just going to assert, we don't have to prove that psychedelics help treat chronic pain. We have to establish it's already been proven. It's there and it's waiting for us. So now what we need is just vigorous research and studies around this. There's exciting research still going on in Imperial College and I believe Michigan on fibromyalgia. Dr. James Close out of Imperial. I'm not sure who the people are in Michigan. I also know that multiple substances are being investigated. So Dr. Devin Christie and Dr. Will Siu did a very fascinating episode on Psychedelics Today a month ago on MDMA and chronic pain. We're going to do a little mini episode on that. But they were able to find from one of the early run-up safety trials to phase 3 MDMA PTSD trials, one called MP16. They found that there was a pretty profound impact on chronic pain via MDMA. And that's not something that's known for occasioning depersonalizing mystical experiences. In fact, your sense of self is in some ways strengthened under MDMA. Yet the middle cluster of chronic pain sufferers, which a high percentage of people with PTSD suffer, they had the largest positive change in their chronic pain. So we'll talk about that another time. But if you get a chance to, I would just, please, it's not a long article and just published on September 30th, 2021. I've been telling everyone that I can for the last year and a half that this is going to happen and it's just a matter of time. But I urge you to read this article. It's a significant sea change, and we could see a lot of people moving to a far better class of drugs. And the reasons why is these are, by all evidence, non-addictive, do not form dependencies from these, and they don't have to be taken chronically. That's one of the main significant benefits that we're seeing in psychiatric conditions. Like people are being, going into full remission, aka healed from depression, from PTSD, from single dose sessions of psychedelics. I see there being, as opposed to standard SSRIs and other antidepressants and psychotropic medications that have to be taken chronically, daily, right? These are like single or double or triple dose sessions spread by 3 weeks, months, 3 months apart, and seeing a very lasting change. So right now they're sorting that out. So maybe this is a drug that you'd only have to take, say, once every 4 months, and eventually, if enough pre-dosing and post-dosing preparation and integration work is done in the form of the correct types of sensory replacement and physiotherapy or neuromuscular rehab is done, we may see rapid resolution of chronic pain conditions, as we've seen from the Albert Lynn's case study. So look forward to talking with you all more about this. There'll be more episodes to come, but please read this article, and thank you again. I'm Court Wing for REMAP Therapeutics.